we'll get started here. Again, thank you for joining us today. As many of you may already know, my name is Meredith Kwok, Associate Director of Alumni and Constituent Relations for the Program in Public Health here at UC Irvine. The Lunchtime Lecture Series is back. This is episode 8, and I'm sure, as you know, the intention of this series is to inform and engage our community in public health efforts happening right here in our backyard by highlighting the work of UCI faculty, all in an easy to digest manner over your lunch. This is, of course, a critical time for public health on a global and local level as our program transitions to a school. So our time is short. I will introduce our speaker who will present, and then we'll open up the conversation for questions. So please use the Q&A function on Zoom, not the chat. Q&A is easier for the presenter. And this will be recorded for future viewing purposes. So, Dr. Brittany Morey is an assistant professor in the newly formed Department of Health, Society, and Behavior at the University of California, Irvine's Program in Public Health, soon to be School of Population and Public Health. Dr. Morey's research focuses on how structural racism shapes racial and ethnic health disparities. Specifically, this work examines how neighborhood, social, and physical environments contribute to health disparities, especially for Asian Americans and Pacific Islanders. He is currently co-investigator on an R01 grant from the National Cancer Institute to examine how ethnic enclaves contribute to breast cancer outcomes among Asian Americans and Latinx. He is also receiving funding from the UCI Institute for Clinical and Translational Science to examine how neighborhood environments are contributing to respiratory disease for Asian American and Pacific Islander subpopulations. Morey received her PhD in 2017 and her MPH in 2011 in Community Health Sciences from UCLA Fielding School of Public Health, and she was also a Chancellor's Postdoctoral Fellow at UC Riverside. Wow, we have had 3 Bruins turned anteaters in a row now. I see a pattern here, so glad you've crossed over to the Zot. So without further ado, thank you for being here, and I'll let you take it away, Dr. Morey.
Thank you so much, Meredith, for that introduction. Let me share my screen. So I first want to start off this talk by recognizing that the campus of UC Irvine is located on the indigenous lands of the Tongva and Ahashiman tribes, indigenous peoples. And I'd also like to note my own position as an academic and as a researcher. Today's talk will be focused on Native Hawaiians and Pacific Islanders. However, I myself do not identify as Native Hawaiian or Pacific Islander. So I don't pretend to speak on behalf of the community, but I have, through doing this work, been able to have the honor of collaborating with and working alongside Native Hawaiian and Pacific Islander academics, researchers, and community advocates. So I hope that in this presentation, I could present some of those things that I've learned to all of you. Now, here on the screen, you can see the title of my talk. But the subtitle of the talk might actually be, and you might have guessed this from my introduction, how has structural racism, in particular, manifested to create a heavier burden of COVID-19 on Native Hawaiian and Pacific Islander communities? So many of you have probably seen some of the news about how communities of color have had higher rates of infection and death from COVID-19. Including among the Pacific Islander community, the African American community, and the Latinx community. And so it isn't that COVID-19, the virus, discriminates against people by the color of their skin or by their race or nationality. But what has happened in this COVID-19 pandemic is that it has really placed a spotlight, a magnifying glass, if you will, on the long-standing structural inequities, the health disparities, and the social inequities that have persisted long before the pandemic arrived. And yet during this time, we can really see this playing out in real time, how it's affecting a particular community. So I want to start off with that frame so that we all are on the same understanding of why Pacific Islanders are burdened by COVID-19 currently. So first of all, what do I mean when I mention structural racism? So racism is defined by Bailey as the ways in which societies foster discrimination through systems such as housing, education, wealth, healthcare, immigration policy, and incarceration. And this is reflected in history, through culture, and through institutions. In other words, we often think of racism as something that's perpetrated by individuals who do racist acts. But structural racism does not need to be the result of intentional discrimination by individuals or even the implicit biases of those individuals. But it could be the result of programs, of policies that end up having a disproportionate burden that discriminate by race. So who are Native Hawaiians and Pacific Islanders, or NHPIs? This is a map of the Pacific Islands, and you'll see that it consists of hundreds of different islands over a large swath of the Pacific Ocean. We categorize Pacific Islanders into three major categories, including Polynesians, which include Native Hawaiians, Takuleans, Samoans, and Tongans and Tahitians. Micronesian groups, which include Guamanian or Chamorro, Marshallese, Chukis, Saipanese, Yapis, Palauans, Pohnpeians, and Coastarians. And Melanesian groups, which includes those from Papua New Guinea, Solomon Islanders, Ni Vanuatu, and Fijians. So you can see how diverse Native Hawaiians and Pacific Islanders are, not only in terms of geography, but also in terms of language, of cultural practices, and also in terms of their standing in the United States. So if we look at Hawaii, Hawaii, as we know, is the 50th United State, but we also have territories of the United States, which include American Samoa and Guam. Now, people from the other Pacific Islands who live in the United States are considered immigrants. And so we can see that there are different histories here and different relationships to the United States. So first of all, how did we get here? How did we get to the point where Native Hawaiians and Pacific Islanders are experiencing a higher burden of COVID-19 cases and deaths? In order to understand this, we need to understand the history and the context in which this pandemic entered into. So NHPIs have had a long and complicated history with colonization. When European colonizers first arrived centuries ago, they introduced with them infectious diseases that almost decimated entire NHPI populations that had no natural immunity to the disease. We also see that the United States has had a long partnership with the Pacific Islands. So the Pacific Islands have long been used as a strategic military outpost by the United States government as a location between the west coast of the United States and Asia. So it was very strategic, for example, in World War II. And after World War II, the US government decided to conduct its nuclear testing on the Marshall Islands in Micronesia. Over the span of 12 years, 67 thermonuclear tests were conducted on these islands. That's an average of 1.6 Hiroshima bombs per day over that entire 12-year period. Now, following this nuclear testing, the United States signed compacts of free association with many of these islands, including a few of these islands, including the Federated States of Micronesia, the Marshall Islands, and Palau. And these COFA agreements allows the United States to have continued military access to the islands in exchange for support for education and health programs on those islands. It allows the migrants from these COFA nations to enter and work in the United States without a visa. These people often come to the United States to work, and many of them work in industries such as meat processing plants. They are not considered US citizens, but when they live in the United States, they do pay taxes. And unfortunately, under the Personal Responsibility and Work Opportunity Act, the COFA migrants do not qualify for federal healthcare benefits, so they have a lack of access to healthcare in the United States. So other islands have had complicated histories with the United States as well. Even if we look at Hawaii, there's been a long history of colonization. After annexation, US colonizers systematically removed wealth and land from Native Hawaiians, such that today we see that Native Hawaiians living there have lower wages, a higher likelihood of being homeless or incarcerated, and a higher rate of chronic illness than other racial and ethnic groups in Hawaii. So despite of this long and often difficult history, many NHPIs are allowed to serve in the US military, and many have risen to this call. Their proportion in the US military is actually 6 times their proportion in the United States population. So I want to give this history in this context so that we can understand how we got to this place of social and health inequity. So what are the social determinants or the underlying social factors that create high risk for COVID-19 among NHPIs? We do see that NHPIs in the US have higher rates of poverty compared to whites. So for example, whites have 7% poverty, whereas Samoans have 16%, Tongans have 16%, and Guamanians or Chamorros have 11% poverty. We also see higher rates of uninsurance, so lack of health care access among NHPIs. Whereas 11% of whites are uninsured, almost 1 in 4 Tongans and Marshallese do not have health insurance, 70% of Fijians, 16% of Guamanians, Chamorros, and 15% of Samoans. We also find that NHPIs tend to live in neighborhoods that have higher levels of poverty and are also exposed to higher levels of environmental air pollution in those neighborhoods. So now we're starting to see how all of these social determinants, poverty, lack of healthcare access, exposure to environmental pollution, how these things can create COVID-19 risk. On the other hand, one of the most beautiful and amazing things about NHPI communities is that they're highly communal. They like to put other people in their community before themselves. They are very familial. And so we find that NHPIs are more likely to live in intergenerational homes. Now, unfortunately, when we combine this highly communal lifestyle with things like poverty, with things like lack of housing access, lack of affordable housing, we end up having situations in which NHPIs are more likely to live in more crowded living conditions, especially in dense urban areas. And we know that in these conditions, if one of those people comes home with COVID-19, that they're more likely to infect their family members. And this also makes it more difficult for them to self-isolate, to quarantine within their home. And so we can see how these can lead to higher risk for COVID-19. NHPIs are also overrepresented in the essential workforce and in at-risk jobs. So I already mentioned earlier how COFA migrants are likely to immigrate to the United States and work in the meat packing industry. Especially, we've seen this play out in Arkansas, where a high number of Marshallese live and work at the Tyson meat processing plants. And there we've seen very high rates. And I'm sure many of you have heard in the news about the outbreaks in the meat packing industry. So we've seen very high rates of COVID-19 in Arkansas among NHPIs. NHPIs are also more likely to work as healthcare aides, as store clerks and cashiers, again in the military, as I mentioned before, as security officers in transportation and delivery, grounds maintenance, and as hand laborers. Now, all of these social factors have contributed over time and pre-pandemic to higher rates of pre-existing chronic conditions, including cancer, cardiovascular disease, obesity, diabetes, asthma, and we also see higher rates of smoking and vaping. And so we know that with these higher pre-existing chronic conditions, that NHPIs, if they were to contract COVID-19, are at greater risk of getting very sick and of dying from COVID-19. So now that I've provided all of this background, let's finally look at what the data say. So from the early months of this pandemic, a group of Native Hawaiian and Pacific Islander students, young professionals, researchers, and I have started collecting data and scraping data on NHPI case rates and death rates in the United States. So you can see here in these selected states that the blue line represents the Native Hawaiian and Pacific Islander case rates over time. And you can see that in each of these states, and in the majority states where we have data, NHPIs are actually have the highest risk, the highest case rate per 100,000 people compared to all other racial ethnic groups. This is true of California in our state as well. And so let's take a closer look at what this looks like in California and in our counties. Now in these graphs, the orange line, the dark orange line, represents Native Hawaiians and Pacific Islanders. And again, we see the same pattern of NHPIs having higher case rates per 100,000 than other race ethnic groups in California counties. I do want to point out Orange County, which is here in the top middle. And you can see that there is higher rates and also this concerning upward trend, increasing case rate that seems to have started around July of this year. So this is a very concerning trend. Now, although I was able to present all of this great data, the story is not complete because we do not have disaggregated data for NHPIs in all states of the United States. These orange states are the ones that report NHPI COVID-19 cases and deaths, but the gray states are the ones that do not report NHPI COVID-19 cases and deaths, either because they do not report the data broken down by race and ethnicity at all, or because they aggregate NHPIs with other groups, including the other race category or into Asian American categories. And what happens is because they are such a small population, the Asian American or other race categories really hides what's going on with NHPIs and hides the disparities that they are experiencing. And I'd like to posit that this lack of data, that data inequity and lack of transparent data can actually be a form of structural racism because data invisibility has some serious consequences for communities. It creates a lack of knowledge about NHPI communities and how they're being affected by COVID-19 in certain states and localities. It creates a lack of ability then to advocate for the needed resources and an inability to target health interventions to the communities that need it most. It also poses challenges to things like contact tracing. Now, it's not all doom and gloom. I definitely want to spend some time to highlight the strength and the resilience of the NHPI community in the midst of this pandemic. So from the early months of the pandemic, the Pacific Islander COVID-19 response team formed. And this is a national team of NHPI community leaders who have gathered in order to address this burden of COVID-19 among Pacific Islanders. It's completely volunteer run. These are leaders from across the nation, and they make sure that in every place where they are working, they have teams that are on the ground that are connected to the communities that they are serving. This group has been able to garner quite a bit of media attention, which has been great. This is one of the articles that was featured about Pacific Islanders, and it features Dr. Reynolds Samoa, who's one of the leaders of the Pacific Islander COVID-19 response team. This effort has also created opportunities for leadership development, and I am very pleased and proud to be part of this NHPI COVID-19 Data Policy Lab. And these are the people here on your screen who have collected and displayed all of the data that you saw today. These are a group of people led by Dr. Ninez Ponce at the UCLA Center for Health Policy Research. And they are mostly young professionals and also graduate students who, again, on their volunteer time, have been scraping data, have been displaying data, have been doing community advocacy and policy work using these data in order to address the problem of COVID-19 among NHPIs. One of the recent developments of this lab has been to create the NHPI COVID-19 dashboard. And so you can see this website at the bottom here is the link. So you can go to this website and you can see all the data that we've gathered. You can hover over states such as Arkansas, and you can see the high case rates. You can see their ranking for NHPIs compared to other racial and ethnic groups. And you can also see the trends over time. You can also hover over the states that do not have NHPI data, and it tells you why those states do not report NHPI data. For example, in Arizona, they report Asian as a pan-racial category that includes Asian Pacific Islanders and Native Hawaiians, and therefore we do not have disaggregated data in that state. We recently had a paper accepted at AAPI Nexus that focuses on these issues of structural racism and the effects on Native Hawaiian and Pacific Islanders in the United States. So it covers a lot of the things that I covered in this lecture today, but it also touches on some other issues that are pertinent to NHPI communities and structural racism, including the higher likelihood of NHPIs being undercounted in the US Census, and also the higher likelihood of being disenfranchised for those who are voting eligible. So the lack of political voice that many NHPIs have in the United States. So if you want more information on those things, you can see or refer to our upcoming article that should be out in the next couple months. I just want to end on some of the recommendations that we gave in this paper. And these are recommendations for addressing those systemic and structural issues that led to the high burden of COVID-19 and other health disparities among NHPIs. The first recommendation is to provide health and demographic data for NHPIs according to the Office of Management and Budget Guidelines. So the OMB has guidelines for disaggregating NHPIs from other racial and ethnic groups, and this is necessary for us to have the data in order to enact change. The second recommendation is that we shouldn't focus interventions only on changing individual level behaviors, individual level health, but we need to incorporate multi-level interventions to address issues at the local level, the county, the state, and the national levels. Third, we need to increase resources to NHPI community-based organizations. And so, as I stated before, the Data Policy Lab and the Pacific Islander COVID-19 response team, it's volunteer run, and they've been doing amazing work. But imagine what they could do with better resources, with better infrastructure for their community organizations. And so the time is now to fund and better resource these types of organizations. Our fourth recommendation is to bolster community capacity through investment in NHPI youth leadership development. And the COVID-19 Data Policy Lab is one of the recent examples of this. And then lastly, the work that needs to be done cannot be done in NHPI groups alone, but it's necessary to build and strengthen coalitions across racial and ethnic groups to address issues that are common to communities of color, including issues of poverty, of housing, of access to healthcare, of immigration reform, of policing, and incarceration. So these are things that affect NHPI communities, and they also cross lines of color and race. And so we need to build these coalitions in order to enact structural change that will benefit all Americans. I lastly just want to thank my collaborators, including the COVID-19 Data Policy Lab, Karina Penaya, Carla Thomas, Richard Calvin Chang, Benan Tran, John Greer, Nicholas Pearson, and Inez Ponce, and our additional collaborators, Alisi Tulua, Sora Park Tanjasiri, Andrew Subika, Joseph Kiave Kaholokula, Paul Ong, and Elena Ong. And I lastly just want to thank and acknowledge Nia Ayatoto and Dr. Reynolds Moa and Dr. Ayatoto of the Pacific Islander COVID-19 response team. And I'd also like to recognize our funders who helped to support the Data Policy Lab. So thank you very much, and I think we have a couple more minutes for questions.
We do. Thank you so much, Dr. Morey. And this second series that we've had has really uncovered some hard truths that are hard to hear and see the data about what's happening in our communities right now. But I appreciate you ending on a positive and hopeful note. And we actually have a number of questions. I may combine a few here, and you touched upon it in your last section, about specific resources or suggestions you're recommending to the NHPI community, you know, how as individuals in a community they could help to reduce this burden of COVID-19, as I said, on themselves. Any thoughts on that?
You know, something that I've learned about the NHPI community is how close-knit they are. And so I feel like for those in the community that you could leverage and use those relationships to get the word out about, you know, safe social distancing, safe practices. You know, it is very difficult, like I said before, to do things like send a family member, you know, to, you know, like to self-quarantine themselves or something like that. So it's almost, antithetical to what many community members want to do. But there are things, and I think the Pacific Islander response team has also tried to put together some resources, and there's a response team here in Southern California that's responding as well.
Okay, one more question here. How does the representation in the medical community impact this data? Are they distributed throughout the native Pacific Islands?
So is that the data that was presented here? Is it distributed to through the medical? Oh, sorry, you're on
I
mute.
believe so. And again, our audience is very concerned about how can these communities help this situation within their group. So do they know by medical providers that these are the challenges that are presented to them?
Yeah, so I think that's part of the hard work that we're doing is getting this data, this knowledge out there to healthcare providers. So the COVID-19 dashboard that I showed earlier is one resource that people can point to for people to get real-time data. It is based in the United States, so it doesn't have current stats on the Pacific Islands. But yeah, I think that there does definitely need to be work done for government institutions to educate healthcare providers about the specific needs of the NHPI communities.
Oh, I'm seeing the clock tick down, and these questions are just coming in so quickly. A lot of thanks. Some requests for the link that you mentioned, the dashboard. So maybe we can send that out in the follow-up email.
Sure.
Let me see. Yes, Audrey shared it here. I'll share it in the chat. Here's just one more we may have a minute for. I think you said about Asian American category data maybe hiding NHPI disparities is so important. In states where NHPI data is disaggregated, do you think there's any way at all for researchers to be able to gather data related to NHPI during COVID?
Yeah, and that's exactly what our data policy lab has been doing. It's been really great that actually we've been using some of these networks and these data to advocate for counties and states to disaggregate, to not use some level of threshold. So some states and counties will say, only if there's 10 or more deaths in this racial category will we report it. So there's actually been a lot of advocacy done in order to have government agencies release that data. And so we've been able to use what we have to advocate for more of it. And so I think that, yeah, so you could visit our dashboard to get the data and to see what we've been able to do.
Thank you. And Nicholas just added the link to the dashboard in the chat. I would like to ask you, Dr. Morey, in your career, has your research taken you to many of these locations and immersed you in these cultures? So
actually, besides Hawaii, I have not visited the other Pacific Islands. I would love to, especially after all this is over. I did have the privilege in graduate school to work with the Native Hawaiian and Pacific Islander communities in Los Angeles. And so that was part of my training in graduate school and very enriching, and obviously has led me to this point to want to continue to do this work.
Well, thank you so much for sharing that with us today. These always come to a close far too soon. And as I said, the questions are still coming in. So this is obviously a topic that our community is very interested in. There will be an email follow-up, again, with perhaps the link and other opportunities and contact information on how to continue your support and engagement with UCI program in public health if you're interested. Thank you, Dr. Morey, for being with us. This is the last of the Lunchtime Lecture Series for now, but I ask you to please keep an eye out. We may have a bonus edition in the evening